We are going to talk about our Brady arrhythmias today and other arrhythmias that you need to be aware of. I would like to start off by just taking a moment of silence, though, in remembrance of those that lost their lives on 9/11. And most of you were not in the military, I was. And it's one of the days that I'll remember for the rest of my life. So let's just take a moment of silence for that, and then we'll continue on. Okay, thank you. All right, so our TLOs and our ELOs for today. Let's do a little bit of review. Gregory, Charles Gregory. Okay, sir, what do you think is going on here? I want you to look at that bottom rhythm strip. Okay, identify is it fast or slow? It's fast, okay? So we got tachycardia, narrow or wide?
Narrow, irregular.
So what are our options for narrow, irregular tachycardia? Yep. MAT, multifocal atrial tachycardia. So a flutter with variable block, atrial fibrillation, and multifocal atrial tachycardia. So what do you think is going on here, sir? MAT. And the reason why? All these P waves, right? We've got a lot of P waves, which is good. We see the P waves. If there was atrial fibrillation, we really wouldn't see those P waves. We might see something that maybe looks like a P wave every now and then, but not clear-cut P waves. Here we have clear-cut P waves, but they're in different morphology, meaning that it's coming from different areas of the atria that are trying to pace or that are sending out different foci. We have different foci in the atria that are sending out depolarization, and we're going to capture that on the ECG. Okay, this should be pretty clear, right? So this is a wide, complex tachycardia that's regular, and then the key is the rate for this, okay? So this is what? VTAC, okay? And what looks similar to VTAC is V flutter, okay? The difference is the rate. The difference is the rate. V flutter is going to be super fast, and the VTAC is fast, but not every single line. It's like every line and a half. So 250, 350 for our V flutter, and then 150, 250 for VTAC. And then also typically the presentation is different. VTAC, that might be coming and walking and talking. V flutter, oftentimes that is not the case. All right, what about Lopez? Okay, what do you think is going on here? Is it fast or slow? What do you think, fast? Slow? Fast? Okay, so meaning fast greater than 100. Okay, is it regular or irregular? If we do R to R. In other words, is this space the same as this space? Is this space the same as that space? Irregular. Okay, so fast, irregular, wide or narrow? Narrow. Okay, so we have fast, irregular, narrow. What are our options? AFib. Okay. Multifocal atrial tachycardia, and then A flutter with the variable block. Okay. So, do you see obvious P waves? No. So that means it's not multifocal atrial tachycardia. Do you see flutter waves? Not really, right? We see a whole bunch of stuff here, but nothing really flutter. We see something there, but we don't see clear flutter waves. So what do you think this is then? This is atrial fibrillation, right? Atrial fibrillation. So again, we're not going to think about, when we look at this, a narrow, complex, regular, irregular tachycardia, we're not going to think about what causes regular tachycardia. We're not going to think about what causes wide tachycardia because that's not part of our differential. And if you can approach these ECGs and even approach the exam this way, you'll be a lot better off than trying to remember all the things that cause tachycardia, all the things that cause bradycardia. You've got to separate them into likes with likes, okay? And it'll make it a lot easier. We have atrial fibrillation. And then, again, if we look at this one, okay, this looks to be the rate itself, the ventricular rate is not that fast. But we have a whole bunch of things in between those QRS complexes. And all those things are the flutters, or the atria are trying to depolarize, but the AV node is preventing all of those depolarizations from getting down to the ventricles. Because if all of those atrial depolarizations got down to the ventricles, our rate would be in the 300s and 400s. Okay, so the fact that at the AV node we have a little bit of prolong in our repolarization, depolarization, is able to block a good portion of those atrial depolarizations from getting down to the ventricle. So we have a high atrial rate associated with this. Okay? And what do these waves look like? Those are our flutter waves. Okay? Those are our flutter waves. And so this is irregular. We've got flutter waves, and that's going to be associated with a variable block. Variable block, meaning that when the atria are depolarizing and it's getting down to the ventricles, the depolarization is not occurring on a regular basis. And then we have this. We have a 75-year-old, let me see, Price. Okay, 75-year-old, CB comes in, long history of smoking, family history of CAD, diabetes, hypertension, got dyspnea, productive cough, wheezing. ECG is done, and this is what we see on our ECG. What do you think is going on with this guy? So same thought, fast or slow? Fast. Regular, irregular? Irregular. Wide or narrow? Narrow. So fast, irregular, narrow. We've got three differentials. Which of those do you think is going on? Multifocal atrial. Wandering atrial pacemaker. We have not talked about that, but we will today. We haven't talked about sick sinus. We will today. Sinus arrhythmia. All of those we'll talk about today. All right. And then this heart, we have multiple foci in the atria that are firing. Okay, but we can't get those full depolarizations down to the ventricles. Okay, and we have multiple foci, not just one. And we have a whole bunch of things in between our QRS complexes that really don't look like P waves. We're not really sure what they are. It's going to be something like an atrial fibrillation. The most common cause of a narrow complex tachycardia that's irregular is an atrial fibrillation. We're still going to continue on with our deliberate approach to reading ECGs. We've already talked about how to do the rate. We've got the counting method, we've got the 6-second method, and we have the 10-second method. Remember, 10-second and 6-second method can be used for anything, but it must be used for irregular or bradycardic rhythms less than 50. Irregular rhythms or bradycardic rhythms less than 50. We're on our rhythm. We already talked about tachy, but every time we look at a rhythm, look at the bottom 10-second strip. And that's going to help us determine the rhythm that we're looking at. So again, is it fast or slow, wide or narrow? And then we've got all of these intervals, waves, and segments that we have to evaluate while we're looking at the rhythm. Okay. So we've got our rate. Okay, what is fast or slow? Is it right, regular, or irregular? We're looking at our rhythm, those QRS intervals, wide or narrow. We're going to look at those ST segments as well, elevated or depressed. What do our T waves look like? What do our P waves look like? Do we have P waves before the QRS complexes? Do we have QRS complexes after P waves? Because if we don't have QRS complexes after P waves, the atria are depolarizing, but what's going on? Why is the ventricle not depolarizing when the atria is sending the signal down there? Something is blocking that. What do our PR intervals look like? What do our QT intervals look like? Bradyarrhythmias are classified as a heart rate of less than 60 beats per minute. We can have sinus bradycardia. Okay? We can have junctional rhythms. Remember junctional rhythms? We talked about if the SA node fails to fire, the junctional area can take over, and that will give us a rate of about 40 to 60. Ventricular rhythms, if the junctional area doesn't take over, the ventricles will, and that gives us a rate of about 20 to 40. And then we can have heart blocks. Now, not all of these will always cause bradyarrhythmias. Not all of these you'll always see, like, if it's not less than 60, well, it can't be a heart block. No. I don't make up these categories. People way smarter than I do say, look, let's put these into the bradyarrhythmias because most often they're going to be associated with the bradyarrhythmia. Most often they're going to be associated with that lower heart rate and not the type of. You can certainly have a heart rate of 60, 70, 80 and still have a heart block. Okay, but we talk about this in association with bradyarrhythmias. There's a lot of different causes of bradycardia. It could be increased vagal tone, a conditioned athlete. And I used to be a conditioned athlete. I still run very, very slowly. And I can tell you my resting heart rate is usually 40 to 50. Okay? When I went in for my appendectomy last year, my heart rate was in the 30s. I was like, man, I am healthy. All right. They're like, well, maybe not. But that was probably due to vagal tone. Probably due to vagal tone. If someone had a myocardial infarction, and more commonly associated with an inferior MI. Inferior MI is associated with usually right coronary artery disease, and that can knock out the SA node. If the SA node's not firing, we're typically going to be more of a potential for that bradycardic rate. Medication, most common cause of bradycardia rate. What common antihypertensive class causes bradycardia? Beta blockers. Beta blockers. So when someone comes in and they're on a beta blocker and their heart rate's 110 and they've been taking their beta blocker, what really is their heart rate, right? But oftentimes these guys will come in, heart rates of 50, maybe low 60s, and we have to look at their medication. So beta blockers, adenosine, calcium channel blockers can also affect the heart rate. Digoxin, most of you guys will not be exposed to digoxin unless you're seeing much older patients who were previously put on DIG many, many years ago. Metabolic derangements like hypothermia, hypothyroidism, which is really probably why my thyroid is or my heart rate is low because I have hypothyroid, can certainly cause that. So if someone's coming in kind of nondescript symptoms and they're like, why is your heart rate always so low? You ask them about their running, you ask them about their activity, but sometimes it's related to thyroid. So you treat TSH on 3 T4. It could be electrolyte derangements like hyperkalemia, stroke or intracranial mass. Okay, how does that affect the heart rate? Well, the CNS system, right? So you have this brain-heart axis, and if you have anything going on in the brain, it can certainly affect the heart rate. It can cause tachycardia, can cause bradycardia. And then Lyme's disease. Any idea? Have you guys talked about Lyme's disease? Look at Lyme's disease. How does that affect the heart? Lyme's carditis can happen. Lyme's carditis. Anybody know the treatment? Ceftriaxone, actually. So, but for Lyme's disease, yes, doxy, very, very good. But for Lyme's carditis, it's actually ceftriaxone. So a lot of different causes. And how might these patients present? Well, they're going to present by the same way they would have tachycardia. A lot of these patients tend to be more asymptomatic with bradycardia than they do tachycardia. Okay? But lightheadedness, dizziness, fatigue, they can have change in mental status, especially if they're older and their heart rate is 20 or 30, they're really not perfusing their brain well. Maybe they feel like they're going to pass out, or they did pass out, and that's what's prompting them to come in to see you. Remember that when you get a number on a piece of paper, that's just a number. It tells you a rate. It doesn't tell you anything about the rhythm. So please don't be reassured that the fact that the heart rate is 60. Well, what is the rhythm associated with that? Okay? What is the rhythm that's associated with it? Maybe that's the problem. So this is sinus bradycardia. How do we know this is sinus bradycardia? What are the two leads we look at to tell us that? Two, AVR. We're looking for an upright P in 2 and a downgoing P in AVR. Okay, we've got that EQRST, and we look at those two leads, and that tells us that this is a sinus bradycardia. So at the bottom here, we have 1, 2, 3, 4, 5, 6, 7, 8, and we times that by 6, which gives us a heart rate of 48. And so this is sinus bradycardia, and depending on what this patient's presenting signs and symptoms are, what medications are on, what concerns you have, maybe there's nothing to do about this, or maybe there is. If they normally have a heart rate in the 70s and 80s when you're doing a chart review, and now they're consistently in the 40s, we've got to figure out why is that. There's something that they're doing that maybe they're not telling you about that's causing this decrease in the heart rate. We have escape rhythms. We know that if the SA node fails to fire for some reason, could be suppressed from acute MI like an RCA occlusion, rheumatic heart disease, respiratory failure can cause a sinus node or sinus node suppression, electrolyte derangement is most commonly hyperkalemia, and then medication. All those can affect the SA node. And if the SA node fails to fire, the heart has this fail-safe mechanism to then have backup pacemaker. Okay, so we know what SA node fails to fire, we're going on to junctional down to, or now starts to atrial down to junctional down to ventricular. Okay. So a lot of times, again, these patients may not have symptoms. If they do, they may have something that's associated with more of a bradycardia hypotension together, so syncope, pre-syncope dizziness. Okay. Now, when we think and we look at these fail-safe mechanisms, we have atrial, we have junctional, we have ventricular. What is that rate for the atrial? 60 to 80. So we don't really classify. I'm going to talk about it because you need to know that that is a thing, but it's not technically going to be classified as a bradycardia. Okay? But we know that the atria can take over the pacemaking functions. So the first thing we'll talk about, though, is junctional escape rhythm. Junctional escape rhythm. This can occur as an independent rhythm, meaning when you look at the ECG, okay, you have a junctional rhythm on the entire ECG. Or it could occur, you have a normal sinus rhythm and all of a sudden degenerates into a junctional. So something, the SA nodes seem to have been firing okay, but now it's not firing, so then the junctional area had to take over. And junctional area is going to be around that AV node. So AV node, just above the AV node, bundle of His, that area. Our rate for this is typically going to be at 40 to 60 beats per minute. And our P waves, either we have no P waves, or oftentimes we might see inverted P waves. Remember, SA node is not firing. The junctional area is firing. When that junctional area fires, it's going to send some of that depolarization back up to the atria. So those atria are going to be depolarized in a retroverted fashion, and that's what causes that inverted P wave. A lot of times with junctional, we don't see a P wave at all. We don't even get that retroverted depolarization. We just get that junctional area. We don't have atrial depolarization. We have depolarization that begins at the junctional area and then goes down to our ventricle. So this top strip here, we have PQRC, that looks pretty good. And then all of a sudden, we have a little bit of a delay. So if we were to measure these out, okay, we would think that we would get a PQRC about right here, but it didn't happen. It didn't, the SA node didn't fire for some reason. The heart says no problem. Okay, I'm going to fire. The atria didn't fire either. And how do we know the atria didn't fire at all? Is because we have no P. No P. There's no P waves associated with these, this rhythm that then is developed after this normal sinus rhythm. So something has happened, the SA node failed to fire, so now the next area failed to fire, the next area took over, which is our junctional area. And the technical definition of an escape rhythm is going to be 3 or more beats. 3 or more beats that's going to change how that heart is pacing. So you could have 3, 4, 5, 6 beats of this junctional escape rhythm, then it might go back to the normal sinus rhythm. So that would still be considered that you had a junctional escape rhythm. If you only had 1 beat or 2 beats, that's something different. We'll talk about that in a few minutes. This bottom strip here, this is a junctional escape or a junctional rhythm. If we look, we have our QRST, no P. QRST, no P. QRST, no P. And junctional tends to be, the QRS complexes still tend to be narrow. So they can be right on the verge of wide, so right around that 3 boxes, but most of the time we think that this is a narrow QRS complex. Yeah, we're going to look for those inverted P wave from retrograde atrial depolarization, depending on what area around that AV node is taking over depolarization. Okay? If you have it lower in the bundle of His that's taking over depolarization, or taking over the pacing responsibility, you're probably not going to see that retrograde atrial depolarization. If it's up higher around that AV node, you're more likely to see those retrograded P waves. So in this top one, okay, we have a retrograded P wave here, and then we get our QRST, and we come over here, we've got a retrograded P here, QRST. This next one, we have a P wave that's actually kind of pushed into our QRS complex. It looks like our QRS complex has a little wave at the end of it. Okay? And then we also see, again, this is much more uncommon, we can have P waves that occur after the QRS complex. So we had a depolarization that occurred at the AV area. Okay? Probably more of the lower AV area. Okay? We've got depolarization immediately of the ventricles, but again, we had some of that depolarization that kind of snuck back up into the atria, but not until after those ventricles were identified on the ECG. Okay? The top one is going to be more commonly what you see, and the second or third one. So this is a junctional rhythm. It's not a junctional escape rhythm. This is an independent junctional rhythm because it didn't escape from a normal sinus rhythm, or at least not that we can see on our ECG. We know this is a junctional rhythm. Our rate here is 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 6 is 54, so we've got that lower rate, right? And we don't see any P waves. There's no P wave, no P wave, none. No P waves anywhere around here. We have our QRST, that's junctional. That's junctional every day with no P wave. If you had an inverted P wave, still junctional. If you have upright, no. Upright P wave tells you that's coming from the SA node. Okay? This is a junctional rhythm, 40 to 60. All right. If somewhere around the junctional area fails to fire, our next fail-safe area for pacemaker responsibility is going to be the ventricles. Again, you can have a ventricular rhythm by itself, or you can have a ventricular escape rhythm. Now, the main difference between ventricle rhythm or ventricular rhythm and a junctional rhythm is that rate and the QRS complex. Because it's coming from the ventricles, okay, we typically are not necessarily using the electroconduction pathways, oftentimes myocyte to myocyte, and so you're going to get widening of that QRS complex. Widening of that QRS complex. We don't usually have any P waves, or their P waves are there, but they're oftentimes within that wide QRS complex. A lot of times, based on the rate, these patients will come in with that dizzy, I felt like I was going to pass out, or I did pass out because that rate was so slow at 20 to 40. So if we look at this top rhythm strip, we've got PQRST all the way through, and we have PQRST. Again, we would think, based on the fact that this is regular from here to here, here to here, here to here, we would think that we would have a PQRST complex that would kind of go around here. That did not happen. The junctional area, atrial area didn't fire, junctional area didn't fire, so now the ventricular area took over pacemaking responsibility. This is a wide QRS. Look how wide those are. Greater than 3 boxes. Where are the three boxes? We have three beats, so that tells us this is a ventricular escape rhythm. Okay, ventricular escape rhythm, wide QRS. And if you see a P, it could be inverted, it could be within that QRS complexes, but the difference is the wide QRS complex in the rate. And so here on the bottom, we have a wide QRS complex, and we start from the beginning of the QRS complex all the way to the end. Okay, wide QRS complex, so Q, we don't have a Q, but R, and then we come down to our S, and this is coming up to our T here. So look at what this little thing is. That's actually a P wave. Again, that's embedded in that QRS complex. So we're getting some depolarization up there, but it's not what's pacing this patient. What just happens to that patient happens to be depolarizing later. What's pacing this patient is this wide QRS, and that's coming from our ventricle. So is this a ventricular escape rhythm? Maybe that's right, because we have, look, P, QRS, a little bit of a T, P, QRS, and then something happens here. It tried to fire. We don't have a P wave here, so something tried to fire. It didn't quite fire, so now we have this escape rhythm that's occurring. And look what happens at the end. It goes back to now the SA node is firing. But in between there, we've got multiple beats of wide complex QRSs, wide complex QRSs, before we go back to our normal sinus rhythm. And so something is causing this to occur. And if this was a tachycardic rate, what would we call this? We call it VTAC. We call it VTAC. We say this person is having episodes of VTAC, and that would be concerning. We have this ventricular escape rhythm here, and if it's a normal rhythm, or a normal rate, so 20 to 40, and if it's associated with a normal sinus rhythm, it might be a little bit higher. As long as it's not tachycardic, then it would not be considered VTAC, it would be a ventricular escape rhythm, which is still concerning. Why is this person's SA node not firing? Why is their atria, junction, all not firing? We're only relying on our ventricular area to fire. And again, we can have atrial escape rates. Atrial escape rates are not technically bradycardic because they're 60 to 80, okay, but they can still occur. That's the number one fail-safe mechanism after the SA node fails to fire. If the SA node fails to fire, the next area that should fire and take over pacemaking responsibility is the atria, using one focus in the atria. So if we have our normal sinus rhythm, which we see here, PQRST, PQRST, come all the way through. Again, if we look at this and we notice that this is regular, we should have a beat that occurs about right here, but we don't. So the body recognizes, the heart recognizes that, okay, I've got something has to pace, and the atria says, I'll do it. So how do we know that this is an atrial escape rhythm? We see P waves. But the P waves that we see should be different than the P waves that are coming from the SA node. P waves that we see are a little bit different. And then the rate is going to change. No longer at 60 to 100, now we're at 60 to 80, so you might see a difference in that rate. Now, what if you took off the entire first half of this? So this whole, you can, if you look in that, you're like, okay, well, yeah, I can see where we have a little bit of difference in rate here, and the keys are. What if you took this entire first half off, block that out of your mind, and you only had this second half? Would you be able to clearly think and say, well, that's an atrial escape? We wouldn't know. We wouldn't know, and I don't expect you to know. So that's not something that you'll see. Like, is this an atrial escape? Or is this an atrial rhythm, or is this coming from the SA node? It's not something I would expect you to know. So we don't have an ECG for that on purpose, because we typically are not going to be able to identify that. Sometimes the ECG machine can identify, and it'll tell you at the top that this is atrial escape, and they're doing that by virtue of how it's looking at the P wave, now how that's being projected onto the ECG paper. Right. So that's it. We've got our junctional, we've got our ventricular. Junctional, typically going to be more narrow, either no P wave or inverted P wave. Okay? Ventricular, wide QRS, much slower heart rate. You might see some P waves, oftentimes buried within those QRS complexes, but it's going to be that wide QRS complex. You're going to see coming from that. All right, next thing we've got to talk about is our AV blocks. We've got first degree AV block. We've got two types of second degree AV block that we'll talk about. And then we have third degree block, also called third degree block. Okay, first degree block. Okay. Lots of things can cause this, but a lot of times it's actually a normal variant. People have a first degree AV block, and they're like, oh, I didn't know I had it. You look at an old EKG, they had a first degree AV block. Okay. It could also be caused by other things like thyroid problems, medications that they're on, electrolyte drinking. So you've got to figure out what is their chief complaint. If they're coming in for a routine physical, they have no medical problems, no concerns, it may just be a normal variant for them. If they have concerns, I have chronic fatigue, I have this excessive weight gain, then there might be a rationale to order medication or order a labs on these people. Second degree, what can cause a second degree? So second degree, we have Movitz type 1, also called Winky-Bach. Okay, that can be from medications, that can be from myocarditis, can be from a prior MI. Okay, and then we have a second degree Movitz type 2. Okay, that is more serious. Autoimmune diseases, pretty significant MI. So type 2 is something that we really get concerned about in patients. And then third degree cocaine. Cocaine. So I was working, this was when I was in residency and I was at university doing, so here's the thing about university, and probably the same thing about university hospitals in any place that you work. People go there to die. Like every person that walks in there, you're like, this person's gonna die. Like everybody is so sick. Like I remember seeing this like 28-year-old who came in for a cough. I'm like, oh man, I'll totally take that cough because I got like some flesh-eating bacteria over here. I've got to do an intubation over here. Like I would totally take the cough. She had a cough, but she has HIV with AIDS. She has leukemia, like all these things. I'm like, and the funniest part of that was, I'm sitting there talking to the patient. Her boyfriend is with her, or maybe it was her husband. I don't know. So I say, well, man, what medical problems do you have? And then she's like freaking off. Well, I've got this, I've got this, I got HIV, I got this. And he said, well, when did you get back? I was like, I'm going to be right back. Because I got to go order some stuff on right now. I was like, oh my God. But another one, the patient I saw came in and he had left. He was discharged from another hospital downtown, and he came because it's, it's University Hospital, it's free healthcare. And he says, they said I have some sort of heart problem, and I need to see a cardiologist, but I don't really know what they said I had. So I don't have any money, so I came here so I could get a referral to a cardiologist. And this guy, we do an ECG on him, he is in third degree heart block, meaning that the atria and the ventricles are not even talking to each other. So his heart rate's like 24. 24, and they just like, because he went to, technically a private hospital. So, any hospital you walk into, they have to see you. It's EMTALA, they have to see you, but they don't have to, that's all they have to do is rule out an emergency. They didn't think this was an emergency. But this guy came in, and guess what his main issue was? Cocaine. Do you do any drugs? Well, cocaine every now and then. Like, how often? Cocaine? Well, cocaine will get you. All right, first degree heart block. First degree heart block. We are looking specifically at the PR interval. Remember all the things we have to look at. Rate, and is it fast or slow? Rhythm, and then we go all the way down to our interval. This is why we look at intervals. We've got PR interval and we have QT interval. So for PR interval, we're going to have it prolonged. Remember, the normal PR interval, we go from the beginning of the P to the beginning of that QRS complex. The normal PR interval is 0.12 to 0.20 or 3 to 5 small boxes. 3 to 5 small. So this is longer than 5 small boxes. Longer than 0.20. We want us, when we're looking at, we got all of those things, we're going last one, we have PR interval, we're going to look. So wait, we're going to measure that interval. And it should be consistent. And it should be 3 to 5 boxes. If it's longer than 5 boxes, it is a first degree AV block. Which means what's happening? Where is something happening at? The AV node. For some reason, the AV node is taking longer to depolarize. Longer for, so that, that slight delay that we normally will see before the depolarization goes down to the ventricles, it's a little bit longer than it should be, which is going to be seen on that PR interval. So longer than it's supposed to be. Again, a lot of times, nothing to do about it. For active duty population, what I would encourage you, like if you have a person that comes in, even if they're completely asymptomatic, okay, and you identify that they in fact have a first degree heart block, if it was me, I would probably just do a routine cardiology consult. Let the cardiologist say there's no other reason for this to occur, right? Because we have the privilege of doing that in the military system, and we owe that to our patients. And the cardiologist may call you and say, why did you send this person? They're going to be asymptomatic. Well, I understand that, sir, or ma'am, but I don't have the capability to ensure that there's nothing else going on in this patient, so that's something that you guys typically do. And then you send them out. Or you could just send, some places they'll allow you to send the cardiology folks an email with the ECG and say this person came in for a routine evaluation, they have no other signs or symptoms, do you have any recommended additional evaluation for this patient or just monitoring? But even though most of them there's nothing to do, you want to make sure that, especially in the active duty population, that we talk to somebody about this at some point. Not emergently, but routinely. Right, so prolonged PR interval, not specifically PR segment, but the whole interval is prolonged. All right, so here we have a first degree AV block. And this is our QRS. We say 3 to 5 boxes. Well, we've got this at about 7 boxes back, right? From our service RP, this is our QRS, 7 boxes back. That is really prolonged. Same thing here. We've got about 7 boxes back for prolonged. This is normal. So what do we have? 1, 2, 3, 4. No, so we got prolonged here. We start from the beginning of our P, that gives 1, 2, 3, 4, 5, about 7 here as well. So prolonged, 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 but it's consistently prolonged. Okay? Every one that you measure is going to be 7, 7, 7, 7, 7, 8, 8, 8. It doesn't go 7, and this one's 8, and this one's 9, and this one's 10. No, it's the same. Consistently prolonged every single time, but the same amount of boxes. Does that make sense? So we're not getting longer. We've long from the beginning, but we stay long from the beginning, the same amount of boxes. Here is an indication of ECG on the bottom rhythm strip of a first degree AV block. If we count our boxes, and we go from the beginning of the P to our beginning of the QRS, this is greater than 5 boxes. And if you look over here, we've got our P, QRST. Our T and our P are fairly close together. Sometimes these patients have such a prolonged PR interval, the P is actually embedded into the T. It's actually embedded. So then you're trying to look for that P. You're like, why is my P not next to my QRS? What is this thing over here? And that's actually your P that's way over there because of the degree of the prolongation of that PR interval. All right, so that's first degree. First degree, prolonged PR interval greater than 5 boxes, and it's consistent. Every one that you measure is at either 6 or 7 or whatever it is, it's the same every single time. Now we have second degree Mobus type 1, commonly known as Winky Bach. Okay? In a Winky Bach, we have this saying, it's longer, longer, longer drop must be a Winky Bach, which means the PR interval It may start out normal, but it changes every beat. So I've got, that looks normal, but this one looks longer. This one looks longer than that. This one looks even longer than that. So maybe we started out at 3. Well, the next one's 4, and then the next one's 5, and the next one's 6, to the point where now we don't even have conduction down to the ventricles. We're dropping a QRS complex because we have a total block, and then it goes back to, looks normal, and longer, longer, longer. And it might be 2 longers, it might be 5 longers, it might be 10 longers before you get that drop. Okay? So it's not always just longer, longer, longer drop. It can be longer, 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 then drop. Right? And I say that because does it always 3 times? No, it can be 4, 5, or 6 times. So here, if we look, we've got our P wave, we've got our QRS, okay, and then we have a P wave here. But if you measure the difference between this PR interval here and this PR interval, can you at least visually see that that's longer? Why is that? That PR interval should not be, it should be the same. It should be the same, and it's not. So we've got a PR interval here, we've got a PR interval here that looks longer, and then we have a P, and we do not have a QRS. Now, some of you might be saying, well, how do I know that's a P and not a T? We're going to, so march these out. March these out. And we don't really see a good T here. We don't really see good T's a little bit here. So this is your, it's like, well, I don't have a P here. I don't have a QRS. So I have a P, but no QRS. And that's going to be your longer, longer, longer drop. So that PR interval should be the same, but if it is extending out, getting longer and longer every time, that is going to be your leaky block. That's your second degree, or your Mobus type 2. Mobus type 1 leaky block. Mobus type 1 leaky block. So your prolonging PR interval, and then you have a drop QRS complex. On this bottom, we have a P, we have a QRS, we have a T, we have a P, we have a QRS, and a T. But again, if you measure this PR interval and you measure this PR interval is longer than this PR interval. And then we have a P QRS T, and we have another P, but where is our QRS complex? We have a drop QRS complex because we have a complete block from depolarization to atrial ventricles. And then the body resets. We go along to back to our P QRS T, but still our PR intervals are prolonging. Here is an ECG with a winky box, Mobus type 1. Can't really tell anything going on here, so we're going to start over here. We've got our P, we've got our QRS, we've got this T, we've got our P, QRS T, so that's good. We're measuring these. So remember, when we're looking at these rhythms, we have a P before each QRS. We have a QRS after each P. So you may not initially identify that we have a prolonged PR interval because we're not at that point yet in evaluating our ECG. But what you can say, I have a P, okay, QRSs, and I've got P, QRST. Wait a minute, why do I have a P here, but I don't have a QRS complex? All of these have QRS complexes, and that's your first indication what's going on. Why am I dropping a QRS complex? Why is that? Now I've got to figure out, okay, is it my PR intervals that are lengthening, or is this a third degree block? So if we measure these PR intervals, we can see a slight difference in these PR intervals. Okay? This is the time you get your calipers out or your piece of paper, because if you look between this one and this one, you can definitely tell. But between this one and this one, some of y'all might say, well, that looks about the same. But if you get those calipers out, you'll see about a half a box difference. In the same way to the next one, half a box difference. So winky block is longer drop, where you have a drop in that QRS complex, and that must be a winky block. Winky block, you have prolonging PR intervals. We have a second degree block, Mobus type 2, again, more significant, more serious complication. Most of these patients have a type 2, end up with a pacemaker. Okay, most of them end up with a pacemaker. So here, our PR intervals are normal, okay? But we have sudden drops periodically of the QRS complex. So PR intervals themselves are normal. When they're there. Okay, we have PR interval. So here, normal, got a T wave, but I have a P wave that has no QRS associated. Here I have a P QRS P wave, no QRS associated with it. And then same thing, but our PR intervals are normal. They're not getting longer. Okay, they're not long from the very beginning and staying long. They are normal. But we have dropped QRS complexes. Something at the AV node is preventing depolarization down to the ventricles. So this bottom one, we have our QRST, and then we have a P. We have another P, and we don't have any QRSs associated with that. Okay? P, QRC, P, 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 QRC. So we have multiple P waves, multiple dropped QRS complexes that is associated with this Mobitz type 2. And sometimes you will have 4 or 5 drop beats consecutively, which means these patients are going to have heart rates in the 20s and 30s, and maybe in the 40s. So they're going to be symptomatic based on the amount of depolarization that actually gets down to the ventricles. If they only have 3 or 4 or 5 depolarization getting down to the ventricles over that minute, they're probably going to be pretty symptomatic. So it depends on the degree of bradycardia, the number of depolarizations that get down to the ventricles will depend on what their symptoms are. So here we have a Mobitz type 2. PR interval is normal. Okay, so P, QRS, we have our T, and then we have another something after that. Again, if we're thinking about is this a U wave? First of all, I want you to think about U waves as pretty darn rare. U waves are pretty rare to be seen. Certainly, if you think it is, you've got to get some electrolytes on these patients. But they're pretty rare. We got P, QRS, T, and we've got something here, okay, and then we have a P wave here. Well, can I figure that out by marching these out? Because my P waves, if my PR interval is the same, my P waves should march out. That's how I know that this is a P wave and not a U wave. Because my P wave should be consistent. Okay, I'm just dropping QRS complexes. And that's how we know that is a P wave. So we have a PQRC, 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 and then by marching out my P waves, I should have a P wave right here. I should have a QRS complex right after it, and I don't. I have a P wave, but I do not have a QRS complex. We do the same thing. PR intervals are normal, but I have these intermittent drop beats, these intermittent drop QRS complexes. And that is your Mobitz 2. Okay, now, third degree AV block. Third degree AV block. This is often the confusing piece. So let's take a break, and then we'll come back and talk about it. Third degree AV block. In a third degree AV block, the atria are firing, the ventricles are firing, but there is a complete block between the atria and the ventricles. The atria said, I'm doing my job, I'm pushing out the depolarization. The ventricle does not receive it, so the ventricles think that they've got to start the pacemaking responsibility. Complete block of conduction from the SA node down to the ventricle. So something at the AV area is blocking depolarization from the SA node down to the ventricles. The SA node seems to be firing okay. The ventricles are not getting that depolarization, so they're going to start to fire. I want you to, where it says atrial rate, it's actually not the rate, it's actually the rhythm. Atrial rhythm is okay, meaning those P waves march out. Same thing, ventricular rhythm is normal. The QRS complexes march out. Okay? And because when we think about rate, we think about what is our heart rate, 40 to 60, 60 to 80, 60 to 100. But here we're talking about the rhythm where the P waves are marching out, and then the QRS complexes are marching out, but they're not talking to each other. Now, can you, on an ECG, see sometimes even in a 30-degree block where a P wave looks like it's right next to a QRS complex? Yeah, sometimes that happens. It happens to fall that way. Happens to fall that way, so it gets confusing. But the rate for this, ventricular rate, is going to be very slow, right? And we're going to have that wide complex QRS, because it's coming from the ventricles. Most of these patients are going to be symptomatic, again, due to the heart rate of 20 to 40, which is the ventricular rate. So fatigue, lightheadedness, dizziness, passed out, especially older folks. All right, so this is a third-degree AV block, ECG. What we're looking at this is on the bottom right, so if we see, we don't really see much over here, but we definitely see looks like a QRS complex here, QRS complex here, QRS, 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 QRS. Does everybody agree that looks somewhat like a QRS complex? Now, remember, this is an electrical conduction problem. So things are going to look different. We're not going to see, necessarily T waves. We're not going to see these big dynamic QRS complexes because we are barely, right now the heart is barely functioning. Right? So may not see those big ones. Up here we can definitely see QRS complexes. We see QRS complexes all over here. So that's associated with these in lead 2. This would be a time if you had the capability to put all your leads down as your 10-second strip. You could put lead V1 down there, and V2 down there, so you can see, like, look, I can definitely see my QRS complexes more prominent in V1, V2 than I can lead 2. So some ECG machines you can just change where that bottom lead is a different lead coming from V1, V2, something like that. But these are our QRS complexes. Here, then here, here, and here. Okay. We also have small little upward deflections here. We have one here, 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 here. Okay. Those are our P waves. Those are our P waves. And although I agree with what you guys are thinking, like, oh, really? Yes, really. We have a little bit of upward deflection. We don't really have, could this be a T and then a P waves in there? It could be. And how do we know? Well, this definitely looks like a P. Okay? This definitely looks like a P. So P waves should march out. Okay? So if I say I've got two P waves that look just like P waves, so this looks like a P and this looks like a P. People, you kind of agree with that. I mean, this looks like, so I'm going to take those P's, and take that, I'm going to take that, and put my calipers on those. And then I'm going to walk my calipers back, and I'm going to say, okay, was there anything that lands in that same spot? Boom. It is. Okay, I'm going to walk them back again. Okay, and that should land in the same spot. All the P waves should march out. And then, so then when you really look closer at this, you're like, okay, well, these other ones seem to kind of march out too. Those must be my P wave. Because third-degree AV block, when you first see it, the number one thing that kind of catches your eye is the rate. Right? Okay, wait a minute. Why is this rate so slow? Now there's not that many things that cause a really, really slow rate. Okay? Why is my rate so slow? Let me figure that out. Do I see P's? Do I see QRS complexes? And do they march out? Because otherwise you might look at this, and sometimes people will get this confused with something like a second-degree block, where we have dropped QRS complexes. But if that's the case, we won't have this marching all the P waves all the way through, and the QRS complexes all the way through. So look at your rate. Look at your wide complexes of those QRS complexes, or wide QRS complex. That's telling you it's coming from the ventricles. If we come back and we look at this, do we have wide complex in this mobus too? No, because the ventricles are still depolarizing correctly. Okay, just not every time. So here we're talking about wide complexes in our QRSs. Our QRSs are wide. And we've got to try to figure out, are they marching out QRS complexes? And if I'm seeing stuff in between those QRS complexes, are those my P waves that are also marching out? So complete disassociation between the atria and the ventricles that are depolarizing. The atria are depolarizing, which gives our P waves. Ventricles are depolarizing, which is giving our QRS complexes, but those QRS complexes are going to be wide, and our rate is going to be very slow. Right. So our summary of our AV blocks. First degree AV block, prolonged PR interval, consistently prolonged. If it's at 6 boxes the first time, it's going to be 6 the next, 6 the next, 6 the next. So prolonged PR interval. Our second degree, type 1. Okay, our second degree, type 1, longer, that's our winky box, longer. Drop must have a winky box, so we have PR interval that may start out normal, but the next one's a little bit longer, and the next one's a little bit longer. And then all of a sudden, we have that drop in our QRS complex. So longer for our PR intervals. Measured from the beginning of our P wave to the beginning of our QRS complex. Our second degree Mobitz type 2. What is our PR interval on that one? Normal PR interval, but then we just don't have QRS complex. Just spontaneous drop of our QRS complex. So you start off, you're like, oh, this looks great, and then you're like, oh, wait a minute here. Looks like I got a P, but I don't have, not followed by a QRS complex. That's a problem. Okay? Because it happens quite frequently when we have a lot of dropped QRS complex. That means a lot of dropped ventricular depolarization. These patients can be a lot more symptomatic, and a lot of times those patients in the pacemaker. Okay? And then our third degree, think about wide complex QRS, very slow heart rate. This is a person that's going to have a history of a myocardial infarction. Okay? It could be from hyperkalemia as well, cocaine use, okay? And they're going to come in weak and dizzy. You're going to look at an ECG. You're going to have, well, you can obviously see ventricular depolarization, but you don't see P waves at every single one of those. But then when you really look, you can tell that those P waves are marching up, but they're not associated with those QRS complexes. Alrighty. On this day in history, we did have a couple of good things that happened. Carol Burnett. Now, you guys are not of the Carol Burnett era. I know that. But do any of you sneak and watch some old Carol Burnett shows sometimes? No. What? Oh my God, I love Carol Burnett. She is one of the funniest people ever. So, Carol Burnett show started in 1967, ran through 1978, so I had like almost 300 episodes of Carol Burnett. So one day, when you're done with phase 1, in between phase 2, if you want really something really funny to watch, that's really good. You might need a couple of glasses of wine before you watch it to make sure it's really, really funny, but trust me, it's really funny. Okay, Atari? No? Ooh. Atari was released in 1977. Oh man, we love. So before Atari, or maybe around that time. Does anybody know what was released around that same time? I think even before Atari. Nintendo. No, but it was the first Nintendo, okay, where it had this round, so like it didn't have any buttons. It just has a big, tall, like remote, and then a round thing on there. And I remember playing baseball, and it was like so 1D. It'd be like, you're out. It was like the extent of what you could get on a year out. And then Pong, a little Pong with it. Oh man, we loved it. We bought it, back then you didn't have Facebook and stuff, so we bought it from the newspaper, from the Muskegon Chronicle. We drove all the way to Muskegon to get this Nintendo, and we paid like $50 for this Nintendo with like a whole bunch of games. And we brought it back, it didn't work. It was so sad. It was so sad, but we took it all apart, we figured out it was just a wire, we soldered it back together, and then it was on. Okay, and then we all know what happened in 2001. We had the deadliest attack on American soil in U.S. history. We had 2 passenger jets collided into the World Trade Tower, killing about 2,600 people. We had a jet fly into the Pentagon as well. And then, of course, we had that flight that was diverted into Philadelphia. So super, super sad. I was alive back then. Of course I was. Because I was alive when the wall between East and West Germany also came down. I was there, by the way. So when I tell you I'm old, I'm not shitting, I really am. Lyman was sitting next to me, he was talking to me the other day, and he's going to get ready to go to Germany. And I said, oh my God, I was there when the wall came down between East and West Germany. He was like, how old are you? I'm like, I told you I'm old. And so I do remember this. I was actually working in a clinic in Lillington, North Carolina. I was doing some off-duty work, and I thought it was a joke. Like, this stuff came on the news. I'm like, this is not even true. Like, this can't even happen. And I was at Fort Bragg at the time, and boy, if you wanted to get on Fort Bragg for the next month, it took you about 6 hours to get on the coast. And most people went to riding their bicycle into work, so we could actually get on coast and into work. So let's pray to God that never happens again. It certainly changed everything that happened. It certainly changed how we think about flying and life. Let's talk about some other arrhythmias that you might see. Okay, so quite a few different things here. We got sinus block, we got sick sinus syndrome, which hopefully you will never see, but if you do see it, it'll be something that you'll be able to, okay, that's just totally wrong. And then we'll talk about a couple other things. So sinus block. When we have sinus block, okay, the SA node appears to be firing okay, but then we skip an entire cycle of PQRST. Entire cycle. So we got PQRST, PQRST, and then we seem to have a delay. And we're like, well, what happened here? Why? So when you're looking at it, it'll look as if it's an irregular rhythm. Okay, but we're missing that entire PQRST. So it looks like it's irregular, but then it goes back to our normal PQRST, PQRST, PQRST. So we're missing an entire cycle. So something, the SA node's firing, but then something stops the SA node from firing, and nothing else picks it up. Nothing else picks it up. Then we go on, just like in rhythm, so we go do, do, miss, but then we go back into normal rhythm. So a complete cycle is missed. And this is indication that something is going awry with the SA node. Now this person may, live to be 100, okay, but this is an indication that something is, why is something blocking this SA node? Then it goes back to firing normally. Something is blocking the SA node from firing. And if we can catch this, when these patients are otherwise healthy, will help them live to be 100. Otherwise, the SA node is going to continue to have these intermittent blocks until it ultimately completely gives out. Okay? So coronary artery disease, for young healthy people, we think about things like cardiomyopathy. Okay? So people that can have hypertrophic cardiomyopathy, that can cause this, and they may not know that they have that, so this might be the first indication that they have cardiomyopathy. And then there'll be other indications on your ECG as well. Okay? So we have a PQRS, we have a little bit of a T here, PQRS. We have, we can see that even our ST segment's a little bit depressed here. But then if we measure these out, here, we should have something right about here, and then we go here. Now, some of you may say, how do I know this is not an escape rhythm? Or some of you may not even thought about that. But you should, because how do you know it's not an escape rhythm? Well, you could have atrial escape rhythms, so that's P waves. You know it because as you're marching this out, it's exact. So meaning I come here, and if I come here, my escape is not going to be exactly the right, the spacing away. So what I mean is if I march this out, I go here to here, I should hit right in the middle. I missed that one, but this marches out exactly, so that miss halfway between, that next beat is exactly on point. If it's escape, we're just a little bit later than what we're supposed to be. This is like, I missed the entire cycle, and when I march this out, my cycle should be here, my next one marches out exactly. Okay, does that make sense to most of you guys? So again, I take my piece of paper, I put it on here, and I put a tick mark and a tick mark. When I move that over, I should have a beat here, and I don't. If I move it over, I don't even have to adjust the paper. This next one goes right on point. That tells you that this is a sinus block, not an escape beat. If patients are having frequent sinus block where they're missing the entire cardiac cycle, oftentimes they're going to need some interventional pacemaker. So if it happens occasionally, it's an indication that the SA node is going to fail at some point when we try to figure out why. So this is a sinus block. If we were to measure these out, so we measure from our R to R, all the way through, okay, that all looks regular. We can see that we have a prolonged period between this beat and this beat. But if we measure this out, it should be about right here, and then this next one follows right in line. So it's not that it's occurring just later, than normal, and actually we're missing that entire cycle from occurring. This entire beat did not form, and then the heart recognized and went back to our normal sinus rhythm. And that is different than sinus arrest. Sinus arrest is 2 or more complete cardiac cycles are missing. 2 or more complete cardiac cycles are missing. So again, we go P, or R to R to R, and we say, wait a minute, I'm missing a beat here. I measure that out, and then I'm missing another beat here if I measure it out, but this one comes right where that next one should be, right in line, and so that's your indication that this is, again, not an escape beat, but actually missed cardiac cycle. This is a sinus arrest. Sinus arrest is 2 or more missed cardiac cycles. Here we have our PQRST, 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 and if we look here, we're missing something that should occur right about in here, okay? If we measure it out, something else should occur, and so do we think this is a sinus arrest or sinus block? Is it missing 1, or does it seem like it's missing 2? Yeah, sinus arrest, missing 2 cardiac cycles, and then we go right on to our next cardiac cycle. And what about this? What does this look like? Sinus block or sinus arrest? Probably a block, right? Because we don't have quite enough space in there. And so it's hard to say because we don't know what happened before here. So if we go backwards though, here to here, we should have something about it here and then there. Which brings us to 6 sinus syndrome. 6 sinus syndrome is this mix of bradycardia, tachycardia, sinus arrest, sinus block. So if we don't catch that these patients are having this sinus block or these episodes of sinus arrest, and ultimately they may go into this 6 sinus syndrome. And 6 sinus syndrome sounds like just what it is, just like what it sounds like. That sinus node is about ready to give out. It is sick, got a cold, and probably worse than cold, probably got COVID or the flu, right? So it is not going to live for very much longer. These patients, I have seen this twice ever, and both times I saw it was in phase 2 of PA school at Fort Campbell, both times. And both of them were older gentlemen in their 70s, and they came in after a syncopal episode, and their heart rate was doing this, really slow, and then super fast, and then slow, super fast. So nowadays, a lot of times you'll hear this reference as tachybrady syndrome, because that's what's happening when tachycardic, bradycardic, tachycardic, bradycardic. Okay? And so we see some slow beats, and then we see some really fast beats. And you see episodes of sinus arrest as well. And based on those episodes of sinus arrest, is oftentimes is the time period where these patients pass out or feel like they're going to pass out. So they'll have some palpitations, and then they'll feel lightheaded, dizzy, and then we have these long episodes of sinus arrest. So this is actually taken from, this is a very long, continuous rhythm strip. So I have them separated here, but if you cut these out, it would be one long rhythm strip where this patient goes from a little bit of a tachycardic rate, so you go 300, 150, okay, tachycardic, and then we have a sinus, probably a sinus block here, then we have this long period of sinus rest, and we go tachycardic, and then it comes down here, and then it comes all the way with sinus arrest, so all of this, and that's how they identify this, because sometimes these guys will go into a normal sinus rhythm, and then they'll go into a tachycardic, and then these sinus. So they monitor them, they put them on a continuous monitor to see if they can capture episodes where they're going in and out of sinus arrest, sinus block, and then this tachycardic, bradycardic. These patients need a pacemaker. Sinus arrhythmia. In a sinus arrhythmia, we have the rhythm that is generated from the SA node, but when you're looking at that bottom rhythm strip, it looks a little irregular. It looks a little irregular. And even though we think about the word arrhythmia as pathologic, this is actually a physiologic problem. And it occurs because some people are super sensitive to, or have super sensitive sympathetic and parasympathetic systems. Okay? Meaning, when we inspire, we take a breath in, okay? This activates our sympathetic system. And most people, or increases the vagal tone. Most people are not going to have any change in their heart rate. People that are really sensitive, they're going to have a change in their heart rate when they inhale versus when they exhale. So on our rhythm strip at the bottom, we're going to see a slight delay, okay, that is specifically associated with that person breathing in and breathing out. Typically at the top of the ECG, it'll say sinus arrhythmia. When you look at the bottom, you'll look and you're watching the patient breathe, and you'll see when they breathe that it matches up specifically. So you might have, how many times do we breathe in a minute? 12 or so. Okay, well, how in that 10-second strip, how long is that? Maybe a couple of breaths. I mean, maybe you'll see 1 or 2 beats on there that will tell you this is a sinus arrhythmia. Okay. And it's all due to these people, again, you don't see it very often, but it's because of the sympathetic and parasympathetic tone is being activated by inspiration and expiration. If we look at the bottom rhythm strip here, okay, so this looks pretty regular, regular, regular. Does anybody see that this looks like it's a little bit further away here? Okay, and then we say, okay, then it looks like we go back. Okay, maybe, so if we march these out, we can see that here it looks like it's a little irregular, a little spot here. We still got PQST, we still got PQST. Okay, our rate seems to be okay. Why do we have a little bit of a change here when we march this stuff out? Again, it's going to take you looking at the patient. First of all, what did they come in for? Do they have any signs or symptoms? And you're going to look and see. When they're breathing, oh, I can see on that monitor or on the ECG that it looks like it's specifically correlated with them. And if you only have 1 or 2, that tells you that they still have their normal PQST. Look up here, upright P, downward P, that this is a sinus arrhythmia. And what do we do about a sinus arrhythmia? Tell them to breathe less. Breathe less. Right? No, we don't do anything about that. Nothing to do. Stop breathing. There's nothing to do for these patients. Most times you have no idea that they have this completely asymptomatic. And it's something that you guys will see, especially in the active duty population. All right, we have a wandering atrial pacemaker. Wandering atrial pacemaker rate is going to be less than 100, so usually 60 to 100. The rhythm is going to be irregular when we look at that bottom 10-second strip. Okay? And we're going to have foci from the atria. We have 3 or more foci from the atria that are sending out. We're trying to pace the heart. Okay, so we have ectopic foci from 3 or different origins in the atria that are trying to pace the atria. So if we have an irregular rhythm, we have 3 or more foci in the atria that are trying to pace the atria. What does that sound like? Multifocal atrial tachycardia. Well, that's this. But our rate is less than 100. The reason for people to get this is the same reason that people get thrown into multifocal atrial tachycardia. Severe respiratory disease, uncontrolled respiratory problems, asthma, COPD, maybe pulmonary embolism. So something respiratory is pushing these patients into the atria that are firing in different areas. We're going to have 3 or more different P waves, but our rate is going to be less than 100. The rate is going to be less than 100. And that's how you determine that this is wandering atrial pacemaker or this is multifocal atrial tachycardia. And this is wandering atrial pacemaker. What is our rate here? Let me see. 96. Our rate here is 96, so less than 100. If we look here, we can see that it's irregular, it's narrow, okay? But we look at our P waves. Here's a P wave, here's a P, here's a P, here's a P, we got P's, Okay, but our P's, we don't even have a P here, a P, no P here. Our P's are looking different. You can look up in these other leads as well. We need to really see it from that 10-second lead to identify that either we don't have P waves for some of these, or our P waves look different. 3 or more different morphologies P waves. In a non-tachycardia. We can sometimes have where we have premature beats that occur in the heart. We can have premature atrial beats, you can have premature junctional beats, and we can have premature ventricular beats. So if I say a premature atrial beat, means it's coming from the atrial, but it's just occurring earlier than normal. Should we have a P wave or no P wave? We should have a P wave. If I say we have a premature junctional beat, it's occurring, we have, you might have normal sinus, and we have a beat that occurs earlier, and it's junctional. P wave or no P wave? Maybe P, but if we have a P, it's going to be inverted. So it's either no P or inverted. If I say we have a premature ventricular beat, what is our QRS going to look like? Wide. P wave? Maybe inside that QRS. But wide QRS complex. Okay, wide QRS complex. So here we have a PQRST, PQRST, and then we have something. So premature means it's happening earlier than what we would expect. So if you march this out, if you have this along your 10-second rhythm, so if you march this out, we have here to here, we would think that our next beat would be way over here somewhere. So this is occurring earlier than what we would expect. So we've got a P wave here, P wave here. We have something before this, and we have a narrow. Okay? If we say that, this looks kind of like a P wave, it doesn't look inverted, okay, we would think that would be a premature atrial contraction. Premature atrial contraction. And then, again, if we were to march this out from here to here, we go from here to here, this next one comes right in line, and that's back to our normal. What can cause atrial or junctional premature beats to occur? Okay. Sometimes increased sympathetic system stimulation, so fight or flight. Sometimes that can occur. So caffeine, medications, like amphetamines, cocaine, hyperthyroidism can cause patients to have frequent premature beats that occur. Okay. Sometimes if someone is having an asthma exacerbation, they're having a decrease in their oxygen saturation, that can also cause irritability, and then premature beats can occur from that as well. So premature atrial contraction, PQRST, PQRST, we're looking at our rhythm, okay? Looking at our rhythm, and if we say here to here, here to here, and then we can tell this one is occurring a little bit earlier than normal, PQRST, and then we have looks like maybe a P wave before there, and then a narrow complex, we have a premature atrial beat. It's a little bit more obvious up here. If we go PQRST, we measure these out. Okay, if you measure this to this, and measure this to this, is there a difference in the measurement from here to here to here to here? There is. This one's actually occurring earlier. And if you can't see that, you can start from the other side of the strip, which gives you more beats. Here to here looks normal, here to here, here to here, but something is occurring from here to here. So we've got our PQRST, PQRST, and then we've got a premature beat here with an upright P and narrow QRS. That is a premature atrial beat, or premature atrial contraction. Okay. And if we look here, we can have that same thing. So premature atrial beat or premature atrial contraction. It's hard to say here because that's our kind of our second beat. Again, if we look from here, PQRST, PQRST looks pretty regular here, looks regular here, and we have something occurring here, looks like it's occurring earlier than normal. We have a P wave that's associated with that. P wave definitely looks different than that P wave. This is a premature atrial beat or premature atrial contraction. Yes, a no tends to reset, and then so something is causing something in the atria to fire, a foci in the atria to fire, it's causing that premature beat to occur, The SA node then oftentimes will reset and we'll go back into a normal sinus rhythm. Yeah. Premature junctional beat, premature junctional contraction. And the same thing is going to happen. If something is occurring earlier than what we would think was going to occur, if we're looking at a normal R to R, normal R to R, and then the next one's like, wait, why is that one earlier than we expect? But oftentimes even more narrow for our QRS complex, and again, either no P wave or inverted P wave will occur. So PQRS, okay, PQRS, a little bit of a T, and then we look from here to here looks normal, here to here looks regular, but this one is occurring earlier, it's narrow, and we don't see a P wave really that's associated with it. Here we have from here to here, okay, that looks pretty normal, here to here, but then we can see that this, when we march this out, this next one is occurring earlier than normal, and we don't see a P wave that's associated with that. Here we have a couple of premature junctional contractions. This isn't a great ECG, but the thing with premature junctional, we don't see junctional rhythms very often. It's hard to get really good ECGs of junctional rhythm because it's not something we see very frequently. We've seen it a lot more post-COVID than we did before COVID because it can cause junctional rhythms, but it's not something we see a lot of. But this is, we have a what looks to be like a kind of a low voltage, you got a P, you got a low voltage QRS, low voltage QRS, we definitely have a P here. And then we have a higher voltage QRS that seems to be occurring earlier, because we should be coming about right here, and then we have no associated P wave. Okay, so if we measure this out to this to here, we should actually have a B that's occurring here, but it's occurring a little bit earlier, and no associated P wave. So again, not great ECG, but if you have a QRS complex that is occurring earlier than normal, no P wave or inverted P wave, and it's narrow, that's your premature junctional contraction. So PVC is going to be that wide in your face QRS complex. It's going to occur earlier than normal. Okay. Again, P wave might be there oftentimes inside your QRS complex, but it's these patients that have PVCs oftentimes are going to come to you with the symptoms that I feel like my heart is beating hard. I feel like my heart is beating in my neck, okay, because it's a very hard in-your-face beat that they can oftentimes feel. Maybe they can't feel if they have one or two of them, but if these patients are having these all the time, they're going to feel these PVCs. So here we have PQRST, and then we have this big, in-your-face, wide QRS complex that is a premature ventricular contraction that's occurring. It's occurring earlier than we would think, which should be about right here, okay? And it's big and wide. Everybody, I'm going to point out the PVC on this one. Okay, so we can see we got a whole bunch of what looks like fairly normal PQRSTs, and we got this big, wide, ugly ventricular contraction. So something in the ventricles is causing to overtake the pacemaker responsibility for this one beat, and then it's going to do that. It's going to be wide because we're having myocyte to myocyte contraction, the depolarization. Now you can get runs of PVCs, and we call that VTAC. Okay? The runs of PVCs, 3 or more PVCs, is technically considered ventricular tachycardia. If it is less than 30 seconds, it's considered non-sustained ventricular tachycardia. Greater than 30 seconds is considered sustained ventricular tachycardia. Okay? Either way, if we have that sustained ventricular tachycardia, we're going to treat this as VTAC. Again, we're not talking about treatments here, but we're going to treat this as VTAC. So we have runs of PVCs that gets very concerning that there is something really irritating going on in the ventricles that's causing this to occur. One of the things that we think about for active duty military, we kind of talked about this yesterday, is caffeine. Caffeine causes these patients to have frequent PVCs. You guys that sit in this class is probably that PVC set up. And if by the middle portion of the day you're like, oh, I think maybe I had too much caffeine today, maybe I need to lay off. You can have something called bigeminy or trigeminy. Okay? Bigeminy or trigeminy. Okay? This can occur with atria, we have atrial bigeminy, and what happens is you have a normal beat, normal QRS complex, and then you have what looks like another beat that's coupled to it, so it seems like it's a little bit closer. And then you'll have a space, and then you have a normal beat, and then you have a beat that is coupled to it. That's bigeminy. Okay, so essentially you're having frequent premature contractions. Okay, they're coupled to every normal contraction. Normal contraction, premature. Normal contraction, premature. That's bigeminy. Trigeminy, if you have trigeminy, you have a normal, and then you have two abnormal beats that are coupled to it. Okay. So two normal, then you have a normal beat, and then you have, so here we have this is junctional, you have normal, and then you have two that are attached to it. Normal, and then two that are attached to it. You have bigeminy and trigeminy. Okay. Things that can cause this, again, something that's called an irritability of the heart. So hypoxia, something that's really anemic, COPD, bad pneumonia can cause this to occur as well. And depending on how often, if this is occurring, routinely, these patients probably need a cardiology evaluation because they're going to be symptomatic. Opposite of premature beats are escape beats. We talked about escape rhythms that can occur. Well, escape beats can occur as well. We know that escape rhythm is going to be 3 or more beats. Escape beat is 1 beat or 2 beats. And if you have 3 or more, then that's going to be an escape rhythm. So again, we have a normal QRS complex, PQRS, PQRS, and then we're supposed to have a beat that occurs, okay? But it occurs a little bit later than what we would expect. Okay? So you can have atrial, you can have junctional, and you can have ventricular. And they're going to look just like we talked about. Atrial is going to have a P, but it's occurring later. PQRS, but that P is going to look a little bit different. Junctional, you might have a P, you might not. If you do have a P inverted, it's going to occur later than we would think. And then ventricular is going to occur later. It's going to be that wide QRS complex. Maybe a P buried within there. So here we have PQRST, PQRST, looks like it's pretty regular, and then we have this whole time frame before something else picks up. Okay? Now yes, is this considered a sinus arrest or sinus block, depending on what the length is? It is, okay? But it's also, we have this, finally get this an escape beat that occurs, and typically that escape beat is not coming oftentimes it's not coming from the SA node. It's coming from somewhere else in the atria that is depolarizing. And then it can go back to the normal sinus rhythm. So you may have 1 beat, and then now the SA node picks up pacing again. You'll go back to a normal sinus rhythm. So here looks like we have a PQRST that looks pretty normal, and then we have this delay, and we have this beat here. So it's a little bit more obvious here. We do not have a T rate that's associated with this. It's narrow complex. This is a junctional escape beat. So the junctional area realized we did not get a depolarization or electrical conduction from the SA node. The junctional area said, okay, I will take over pacemaker responsibility, and it did that for a beat, and then the SA node said, nope, it's my job. I'm going to start pacing us again. Okay, so 1 or 2 beats has happened. So this one's just 1. And then look, we're right back to our PQRST, PQRST. So SA node started to fire again. So we have a beat that occurs later than what we would expect. Not coming from the SA node, it's either coming from the atrial focus, or from a junctional, or from a ventricular focus. And then we go back to our normal PQRST. The SA node starts firing again. So this bottom PQRST, PQRST, we have a delay. So the SA node didn't fire, the atria didn't fire, the junctional area didn't fire, the ventricles ultimately fired, It gave us that delayed beat, that escape beat, and then we went back to the SA node firing. And so something is going on with the SA node that is having these episodes where it's not able to fire. So what is the difference between an escape beat and a premature beat? Escape beat is occurring later than we would expect. Premature beat is occurring earlier than what we expect. It could be atrial, it could be junctional, it could be ventricular. It's just later versus earlier. And you do need to know that, because you'll see, I'll give you something like that. Just know, if you're marching things out and it's occurring later than it's supposed to, that's escape. Okay, if it's occurring earlier, then that is premature. All right, fact or fiction? And matter of fact, I was listening to a podcast this morning that talked about this. Number the top one, fact or fiction. Okay, let me see here. Oh my gosh. Okay, semantic. Oh, I can't say it. Jordan, sure, how do you say that? Huh? Semantic. Okay, Jordan. Fact or fiction? Green mucus equals infection, and you should give these patients antibiotics. Fact? Fiction. Not true. The podcast I was listening to this morning was talking about this specifically, and they were talking about antibiotic stewardship. And they talk about antibiotic stewardship. Patients come in, and one of the main reasons why we give antibiotics for patients is bronchitis. Bronchitis is viral. And if you have a diagnosis of bronchitis and you give antibiotics, you're going to get a flag for it every single time, right? I mean, come up with something else. Say it's sinusitis. Don't say it's bronchitis. Okay? But often when people come in and say, I think I have a sinus infection. How long have you been sick? Oh, I got sick yesterday. It's not a sinus infection after one day. Well, I've got green mucus coming out, so it must be a sinus infection. We have to educate our patients that what color is boogers? Boogers are green, right? And that's the same stuff, you know. So just because it's green doesn't mean it's an infection. Green often comes from it's like a mixing of cholesterol in the mucus that causes the discoloration of the mucus. Right? So yes, if someone comes in and been sick for 2 or 3 weeks, and they're coughing up brown sputum, that's blood-tinged sputum, yes, sure, but we've got to look at the longevity of these signs and symptoms and not just the color of it. So it's all about patient education. And if we spend more time educating our patients, patients educate their friends as well, and they're a lot less likely coming in. And really, a lot of these patients you'll find are going to demand antibiotics. They demand antibiotics. Now, I'm not a person that gets into a big altercation with somebody about antibiotics. Like if they're coming in and they're not going to leave my office and I give antibiotics, guess what? I'm going to probably give them antibiotics. And I'm going to document, like I talked to this patient multiple times about their risk associated with taking antibiotics, and they verbalized understanding, and they still insisted on having these antibiotics. But I try to just educate these patients. If you take the time to do that, most of the time they leave your office and they're fine with it. Okay? What about moss? Okay, man, what do you think? Generic medications are just as effective as brand name. True. They're supposed to be. That's why they're designed. They're designed to be a little bit cheaper, right? But for the majority of generic medications, that is true. There are some, depending on people who have like absorption issues, like celiac disease, or something like thyroid medication. Thyroid medication, for some patients that have hypothyroid or hyper, and then ultimately have to go on Synthroid after treatment, some of those patients can only take brand name because it affects their TSH. So the majority of generics you should be able to give them. In the military system, we don't have a choice. We have to give generic, okay? Unless there's some other reason. Okay, and then what about, I love this one because we all know the answer. Rivera Rosado. Okay, ma'am, getting the flu shot will give me the flu. It's impossible. Maybe the place that you went to get the flu shot had other people that were sick, right? But flu is an inactive virus. But I'm telling you, my grandmother swore every time she got the flu shot, she got sick. But really, there's nothing that says that that is the truth. Okay? It's an inactive virus, and so technically it can't. Now we did for a period of time have the activated flu. Some of you guys may remember that we did intranasally, and that certainly did get quite a few people sick. But in general, the flu shot is not active. Okay. So we educate our patients about that. All right, pre-excitation syndromes. Yeah, I think we can get through these two. So pre-excitation syndromes, we got WPW and we got LGL, low gain on Levine. So pre-excitation syndrome, what is occurring here? We have an accessory pathway. We talked a little bit about pre-excitation, or WPW at least yesterday. We talked about ABRT. And we said in ABRT, which is a tachycardic rate, most of the time ABRT, what we think about is WPW with tachycardia. That causes ABRT. So people have WPW, they don't always have a tachycardia rate. They're not always in ABRT. But if they go and they have a tachycardia rate, a lot of times it's going to push them into that SVT, that ABRT. Okay. Wolff-Parkinson-White can be on it has this accessory pathway between the atria and the ventricles. It can be on the left side or it can be on the right side. Okay. And then long gain on Levine, that is an accessory pathway that bypasses the AV node. That's important, right? Because the AV node, we need that AV node to kind of control our depolarization from the atria down to the ventricle. So Wolff-Parkinson-White. And when we think about Wolff-Parkinson-White, we have that accessory pathway. Okay, it can be on the right side, can be on the left side. We have depolarization that is occurring in a normal fashion, from SA node down to the AV node down to the ventricle. But you also have some of that depolarization that's going down through that accessory pathway. And because we have that depolarization that is coming down through that accessory pathway, it results in the ventricles depolarizing at slightly different rates. If we have ventricles that are depolarizing at slightly different rates, how do you think that's going to appear on our QRS complex? What is it going to cause our QRS complexes to look like? Slightly wide. Slightly wide, okay? Because that depolarization is different. Okay, I take it back. We're not going to be able to finish this. When we meet next, we will go back over this, okay? Because I want you guys to understand this.